All right, what's unusual about this disease is this is an entity that is not yet molecularly defined. What do I mean by that? We don't take a hemoglobin A1C to define it. Ultimately, we have a multidisciplinary discussion for agreement as to what this idiopathic entity is. So this study by Kevin Flaherty a number of years ago is still the gold standard for how we approach the diagnosis, in which he took a group of clinicians and radiologists and pathologists. And in step one, he simply asked them what the diagnosis was in a separate room, and then put them together to discuss it, and then finally added pieces of data to see what the influence was in the consensus and diagnosis. And it should be no surprise that when you take a look at the kappa statistic, which is the level of agreement among clinicians, radiologists, pathologists, that they simply improved as people got more data and talked to each other, which is what this slide really shows you. The most important steps aren't between 1 and 2. This is where people kind of came together a bit. It's really between steps 3 and 5. When the groups started to add information and discuss it in a room together, the level of agreement improved across the board, both between academic clinicians, academic radiologists, and academic pathologists. Now, what's fascinating is there was a recent data published in a paper just a few months ago that demonstrated that you didn't need to be an academician to be that smart at this. It really had to do with how old you were and how many cases you had seen. And so the people who do a lot of this get very good at it, and particularly when they talk to their colleagues. As we integrate that data, looking at the impact of a multidisciplinary team discussion on the IPF diagnosis, this study by Joe et al. Really helps demonstrate the impact. What we see is that once patients were referred to a center, the multidisciplinary meeting really changed the diagnosis in a significant number of patients. More importantly, it increased the number of monitoring from pre to post, increased exposure to clinical trials, increased the weaning of prednisone, increased oxygen use, increased pulmonary vasodilator use, antifibrotics, and increased steroid-sparing agents while reducing overall steroid use.